very simple. And when we talk about apnea in babies, there's two types of apnea. One is primary apnea, and that's typically apnea of prematurity. So we think of it as immaturity of the baby's brain centres, but it's actually a little bit more complex than that. The other is secondary apnea, and we've all had the experience of whenever a baby gets sick, one of the first things they do is become apneic. So you can have primary or secondary apnea, and they're obvious causes for needing ventilator support. There's no way around that. The other reasons why babies need ventilator support is inability to oxygenate. In our nurseries, that's primarily parenchymal lung disease or inability to ventilate. Now, there are a number of reasons why you can have problems with CO2 exchange. One is it's often linked to parenchymal lung disease, so you have a combination of oxygenation and CO2 exchange problems. But we also see a need for respiratory support for CO2 problems when there's central nervous system depression. So one of the more common causes in our nurseries would be a baby's having asphyxial insult, and their brain is severely affected, and they don't have any respiratory drive. So their lungs are essentially normal, but they have no drive to breathe, and we need to ventilate them. Now, there is an important distinction between ventilating for parenchymal lung disease and ventilating for central nervous system depression, because the lungs in a baby who has, say, had an asphyxial insult but has normal lungs, you can't ventilate them the same way as you do a baby with respiratory distress syndrome. So these babies, they have generally normal compliance, so they fill and empty a little bit slower. They don't need significant pressures to generate tidal volumes. They exchange CO2 very well. So one of the big problems with ventilating babies who've had, say, a hypoxic ischemic brain injury is that if you're not careful, you can overventilate them, drop their CO2 dramatically, and the response to that in a newborn baby is that the blood vessels in their brain supplying all the critical areas that have had an asphyxial insult constrict down in response to the low CO2s. So you're actually restricting delivery of blood to an area that's had a hypoxic ischemic injury. So you're likely to be increasing the severity of the injury if the baby has a very low CO2 for a long period of time. So we do need to think about why we're providing respiratory support and how we set up our ventilator so that we don't cause harm by trying to do the same thing for all babies. When is supplemental oxygen enough? When there's no apnea, adequate oxygenation, and primary problem is hypoxia. And we do see that in certain circumstances. So babies who've got good respiratory drive, they only have relatively minor lung disease, and all they need is some supplemental oxygen. And we talked about yesterday how supplemental oxygen works, basically just increasing the amount of oxygen molecules here, which improves vasodilation of the capillary networks passing these lung units and improves oxygenation that way. When supplemental oxygen is not enough, it's typically because we've got alveolar and airway collapse, and the oxygen, of course, can't correct the low lung volumes. So I talked about yesterday how the baby themselves tries to compensate for that. So they increase their respiratory rate, decrease their expiratory time, stop the lung from completely emptying, and grunt. And these things both generate lung expansion and improvement. So when we think about ventilating, we've gone to the point where we need additional ventilator support. It's good to actually sit back a moment and just think about what are actually our goals when we put a baby on ventilation support. So the first one is to overcome alveolar atelectasis by splinting open the airways, splinting open the air sacs. The next goal is to achieve adequate pulmonary gas exchange, and that's usually achieved by just driving gas in and out with the ventilator. But also importantly, we want to increase the patient's work of breathing. And in a very small premature baby, that's very important because these are the ones, they don't have good muscle endurance. So if they have to work hard, they often tire very quickly and then they will just collapse and have serious apnea. We want to keep them comfortable. We know that a baby who is very uncomfortable, in pain, in stress, it actually impacts on their brain development. So it's important that we keep our patients comfortable. And lastly, when we first started ventilating babies around the late 1950s, 1960s, for the first time we started to see a particular type of lung disease in babies called bronchopulmonary dysplasia. And it was then that we realised that the ventilator and oxygen had the potential to cause serious lung disease. So much of the work and the thought we put into ventilating babies now focuses on the last goal, and that's trying to avoid ventilator-induced lung injury as much as possible. So a lot of the technologies that have developed over the last 20, 30 years primarily focused on avoiding lung injury. It's good to think about why pressure support is beneficial. So apart from just having surfactant deficient immature lungs, the newborn infant, and particularly the premature infant, has what I call a mechanical disadvantage. So there are a number of things about, there are design faults in the way a premature baby is. So the first thing is that in the preterm baby, during the birthing process and soon after delivery, postnatal clearance of lung fluid in the prem baby is much slower. And they can even actually continue to secrete lung fluid from the interstitial tissues into the alveolar sacs and airways after delivery. Now, the impact on this when you start air breathing is it effectively reduces your lung volume and functional residual capacity because you can't ventilate through the fluid. The other problem with these babies is their upper airway, the pharynx, lacks support of these soft tissues. And so the upper airway collapses down, particularly during inspiration. And that causes significant problems for the baby. The newborn's chest wall is very compliant, and you see that when a baby isn't on a ventilator and they have respiratory distress, their chest caves in, their ribs cave in. And what that means is that their breathing is very inefficient. So as the diaphragm descends and creates negative pressure in the lungs to draw gas in, this also causes the chest wall to collapse in and makes it very difficult to generate tidal volume. The way the diaphragm in the preterm baby is arranged is it's quite different to us. Our diaphragm is quite domed, and the reason for that is that during contraction it's a very efficient way to work. The preterm baby the diaphragm is flatter, and so rather than being able to contract and expand down like that, it's more like that. It doesn't work as well. And of course you've got problems of surfactant deficiency, decreasing lung compliance and promoting small airway collapse. So the next step is in respiratory support is typically continuous positive airway pressure. So why does that make a difference? Why does CPAP relieve apnea? And we know that a lot of babies who are having apnea, if you actually put them on CPAP or increase their CPAP support, their apnea disappears. Well, there's a number of reasons for that. So primarily what continuous positive airway pressure does is it just applies the pressure to the baby's upper pharynx, which then is transmitted down into the lower airways. And the first thing it does is this positive pressure in the airways promotes reabsorption of lung fluid. And that's one of the reasons why in the delivery area, when we resuscitate babies now, it's routine to use CPAP. Part of the reason is that it promotes reabsorption of lung fluid, but it also splints that floppy airway open so that you don't have airway collapse causing obstructive apnea, and it recruits adequate lung volume. And by recruiting the adequate lung volume, you minimise the energy expended with breathing. You actually enhance exogenous and endogenous surfactant function. You improve pulmonary vascular resistance, and you start to optimise perfusion mismatching. And so CPAP actually corrects a range of problems. It's not just about holding functional residual capacity. It actually, particularly in the immediate newborn period, has a lot of purposes. So CPAP, and that's why babies who are on CPAP, who you would think possibly need ventilation, will sometimes stabilise dramatically just with the simple application of CPAP. The optimal way to provide CPAP is still thought to be the binasal prongs, although a lot of hospitals now are using nasal masks. The main reason why the nasal mask was developed was not because it's a better form of CPAP, but because the nasal prongs can cause trauma to the nose. And in fact, what we do in our nursery is we alternate. We go nasal prongs for some hours, nasal mask for some hours, because the nasal mask also can cause injury to the bridge of the nose. And so we use the nasal mask just to try and reduce the trauma, not because it's a more effective form of treatment. So one of the things that sort of identifies the importance of these binasal prongs is when I go to delivery, we use a CPAP mask to initially resuscitate the baby. And the baby starts breathing, but they often, when they're on the mask, they have relatively high oxygen requirement and relatively big work of breathing. And people are saying to me, should we intubate this baby? And I explain to them that using the big mask over the baby's face is not a very effective form of CPAP, because you've got the pressurisation in the mask and you're just trying to transmit that through the little nostrils. And what we do is we have our transport cot in the delivery area with a setup, proper CPAP setup, and we put the baby straight onto CPAP. And it's really amazing the difference just putting the baby on binasal prongs makes. You often see the oxygen requirement come down quite quickly, the work of breathing noticeably improve, and in effect you're still using the same CPAP pressures. And certainly in some hospitals, it's actually routine in the delivery area when you're going to a preterm delivery, is to have actually a proper CPAP set up right there at the bedside. And as soon as the baby starts breathing regularly, we put the baby onto the binasal prongs because we recognise that it's the most efficient way. One thing that's not good is doing CPAP on the endotracheal tube for a long period of time. And that's because it's a very narrow tube, so the resistance in it is very high, and the work of breathing for the baby is quite dramatic. So we do use endotracheal CPAP to look at the baby's respiratory drive just for a few minutes, but we never leave them on it for any prolonged period of time. Okay, now, unfortunately, nasal CPAP doesn't always work. And one of the questions is, when do you decide that the baby should go from nasal CPAP to endotracheal intubation and ventilation? Now, I think it was in the late 1990s, maybe early 2000s, that there was a trial called the COIN trial done. And the COIN trial was quite a significant trial. What they did was they randomised babies to, in the immediate newborn period, either to elective intubation or starting on nasal CPAP, and trying to work out whether there is advantages in intubating all babies or whether we can start babies on CPAP. It was a very good trial, but there was one big problem with the trial. I can say this because I was around when this trial was being designed. The trial investigators didn't want clinicians going to CPAP really quickly. Going from CPAP to ventilation really quickly. So they set criteria as for CPAP failure is very high. So a CO2 of more than 60, but more importantly, an oxygen requirement of more than 60%. Now, as clinicians for a long time, we recognised that if you allowed the oxygen requirement to get very high before you decided to intubate those babies, by the time you intubated those babies, they were in a really bad way. And they often got into big trouble because you were trying to intubate them. And so as clinicians, we would typically say much lower oxygen, but because this was the trial, we had to follow the trial criteria. Now, the big problem with the COIN trial is that nearly 10% of the babies who started on CPAP were getting pneumothoraxes, which was very high. And that was compared to the ventilator group of only 3%. And you would actually think it should be the other way around. You're more likely to have a pneumothorax if you're on a ventilator than not if you're on a CPAP. And in fact, some of the babies had full cardiorespiratory arrests as they were being prepared for intubation. So the Europeans will often talk about the COIN trial as a good example of you shouldn't do this. Now, subsequently, the Europeans did a similar trial called the CURPAC trial, and they set an intervention of greater than 40%. And there was no difference in their pneumothorax rate. The other big issue is when we talk about CPAP failure, and this was one of the problems with the COIN trial, is you have to consider work of breathing, and you also have to consider the severity of the lung disease and how far it's going to progress. So most places now, they have a set oxygen requirement, at which they typically go from CPAP to ventilation if the baby starts on CPAP. But also they look at the baby's work of breathing. And the other thing they do is they look at the initial chest X-ray. And so like in our nursery, if the baby starts off on CPAP, we get the baby up to the nursery, we try to settle the baby, we get a chest X-ray, we put an intravenous line in, then we sit back and watch. And our trigger points for babies under about 30 weeks, we're going from CPAP to either intubating or at least giving surfactant by the ensure or mist technique, is an oxygen requirement of more than 30%, significant work of breathing. Or if you look at the chest X-ray and it shows very severe lung disease, then we have a much lower threshold for intervention. So how does let's move on to mechanical ventilation. As I sort of explained yesterday, mechanical ventilation is in fact a very simple principle. You force a volume of gas under pressure from the upper airways into the terminal airways and air sacs, and then the baby passively exhales due to elastic recoil. And this improves alveolar ventilation and corrects alveolar hypoxia, corrects right to left shunt, and increases CO2 elimination. But there are big problems with ventilation. So we talk about ventilation-induced lung disease or ventilation-induced injury, VILI. And there's a number of forms of ventilator-induced lung disease that can occur in. One is air leak syndrome, so that's pneumothorax or interstitial emphysema. And I'll just use the whiteboard to explain that, because it actually is really helpful to understand what these terms are. So if we think of the terminal airway and the air sac, as we drive gas in and out, particularly in large volumes and at high pressure, the airways themselves, there's very little movement, but the air sacs, there's big movement. So you have this point here of what I call shear stress. So that means that you've got a point where there's a sudden change from little movement to big movement, and it's a weak spot. So if we've got like the interstitial tissues surrounding the terminal airway. And what happens is, in air leak syndrome, you get a rupture here, and then under pressure, the gas is forced into the interstitial tissues. Now, in pulmonary interstitial emphysema, what happens is that gas stays trapped in the interstitial tissues. So you have a lung that has airways and air sacs surrounded by interstitial tissue that has now got a large volume of gas trapped in it. And it's like applying a tight binding to the airways and the alveolar sacs. So the problem with interstitial emphysema is you now have a very poorly compliant lung. You have to keep increasing the pressure to get tidal volume in there. And as you keep increasing the pressure, you drive more gas into the interstitial tissues. And so pulmonary interstitial emphysema is actually a very, very serious condition and something you really want to avoid, because it can, apart from the fact that it can be life-threatening, it also can make it extremely difficult to manage. And there are techniques for doing it. When it comes to pneumothorax, what happens is that tissue, that air keeps dissecting all the way up to the mediastinum of the lung, and at that point ruptures through into the chest cavity and fills the chest cavity with gas and collapses the lung down. Now, the positive side of a pneumothorax is you can put a chest drain in, get the air out, correct the problem. That's the plus side. The bad side of pneumothorax is the way the pneumothorax often presents is you have an acute collapse of the baby. They're just going along quite nicely. And what typically happens is they become suddenly hypoxic. They lose their cardiac output. They look shocked. They become bradycardic very quickly. And in that time, you can develop a severe intraventricular hemorrhage, particularly grade 4 hemorrhages. There's a very strong association between pneumothorax in the first few days of life and IVH. So both these situations are really, really important to avoid. When I was working in the United States, in our department, the way they approached pneumothorax was, if your baby had a pneumothorax on your shift, it was your fault, and you were in heaps and heaps of trouble. So we were always really scared babies having pneumothorax because of the amount of trouble we'd get into. So we were really, really careful about pneumothorax, and we also understood the physiology and the ventilation strategies, how to limit it. And our pneumothorax rate was very low. In fact, some of our trainees went through their whole training time, and we were a very big nursery without ever putting in a chest drain. So the way you approach ventilation does affect your rates of pneumothorax. Now that doesn't mean that when a baby has a pneumothorax it's somebody's fault. We know that spontaneously breathing babies with respiratory distress can have a pneumothorax. So just the disease process itself predisposes the baby to the pneumothorax, but we do know that what we do with the ventilator can significantly increase the likelihood of the baby getting that pneumothorax. The other problem that is related to ventilator-induced lung disease is chronic lung disease or bronchopulmonary dysplasia. And this is a really big problem. Even in the best nurseries, babies under 750 grams still have a very high rate of BPD. Now there's a number of reasons for that. BPD is a very complex disease, and there's a whole range of things contributing to it. So it's very unlikely that one or two strategies will ever prevent it. So when we first developed surfactant, we thought it would fix chronic lung disease, but it didn't. When we first developed high frequency, we thought it would fix chronic lung disease, and we didn't. And a whole range of things that we've done have actually had very limited effect on chronic lung disease. But we do know that if we use bad ventilation strategies, the rates of chronic lung disease are much worse. So I recently saw a presentation from a person from the United States, and the topic of her talk was, how do we prevent chronic lung disease? And the first slide was, we can't. And then she said, that's all I can say. Went on to spend the next 5 minutes showing us slides of her cats. And then she started to talk about the all the experimental evidence. But basically, over the last 20, 30 years, we've had minimal effect on chronic lung disease realms. But what we do know about chronic lung disease is that there's experimental evidence that suggests that high end expiratory lung volumes and repeated collapse and reopening of alveoli with each breath are important contributors to ventilator-induced lung disease. So we first started talking about volume-related injury from tidal volume when a person did a series of experiments where he took premature rabbits and half of them he wrapped their chest in a plaster cast and half of them he didn't. And then he put them all on ventilators and used very high pressures. And what he found was that the premature rabbits without the plaster cast got very severe lung disease very quickly and they all died. The premature rabbits that had the plaster casts that limited the chest expansion, even with high pressures, their lungs weren't too bad because they couldn't get the tidal volume injury. So that's, from that point, we shifted away from blaming it all on pressure to acknowledging that whilst pressure had some influence, tidal volume was very important. And the other concept is something called atelectotrauma. So what we know that when lungs are held at low volumes and you ventilate them, at the end of each expiratory cycle, the airways and the alveoli collapse right down.